BiPAP, and then maybe you're going to get better. Or I mean, I have trouble getting my brain around, and I never even knew until tonight that CPAP and COPDers. I don't. I guess I'm having trouble following why it's better.
Why which is better?
Why BiPAP is, at least from what I'm understanding, unless I'm totally misunderstanding, BiPAP and a COPD bronchospasm kind of.
Well, it seems to make sense to me, because if those people are having issues breathing out,
right,
then you're giving them more pressure to breathe in and less pressure to breathe out.
They need the lower pressures, but
you're still,
yeah, but I mean, you're throwing an awful lot of inspiratory pressure in at the start using 10. You know what I mean? If you're going to start at 10 and 5.
But it's that gradient. So you're suddenly dropping that pressure.
Okay.
And that's what lets the air get out.
And that's going to help them. So the upper pressures, they're not at the risk of barotrauma from that. At least the increased inspiratory pressure is not.
Not if we're staying in the recommended ranges, right? Because when we're on a ventilator, we're generally not worried till it gets up to 30 or so.
Right. Okay.
But the difference, like you said, is that we're not definitively in their airway. So some of this pressure, if it gets too high, can end up in the esophagus.
I guess, yeah, that makes more.
So is that?
Go ahead.
No. Well, is that why it's more comfortable for them, because the drop in pressure is not constantly?
I don't know. I've actually, well, I think maybe once I tried BiPAP for fun, but I don't know. I don't remember.
All right, Becky, go grab a mask.
You didn't start with
I'll
a
beer. I'll tell you what it feels like. Go ahead.
I guarantee you, I'll put
Respiratory
myself on
therapist next week. Medical students.
Probably. We'll end up having to work each other out.
Shift change next
All right,
Wednesday.
let me quick finish up, and then we'll do the cases.
Does that make sense? Though, Marcus?
It does, and I guess I understand the pressure gradient. It's comfortable. It's helping the air out. But I was just wondering, at what point is that increased pressure going to increase the risk? You know, at least the inspiratory pressure.
I put all my COPDers on BiPAP.
Okay.
I don't put them on CPAP.
Okay.
Do you use CPAP at all in the ER?
CHF.
Do you?
Well, I called you for that bad CHF guy I had a week or two ago. I was using CPAP for this guy, and he wasn't doing that well. I had RSI coming, and I asked him what he thought about BiPAP, and he said CPAP was just as well for him.
Yeah, CPAP is my kind of go-to, but similarly, if that patient wasn't tolerating it and we could do BiPAP, then that's probably worth a shot.
Sure.
Now, if they're not in cardiogenic shock, will you hang a nitro drip?
Yeah. Let me not. We got some cases to go over. All right, so we talked.
Jump forward though.
Well, I mean that is an issue.
Yeah.
I mean, having to take that mask off every few minutes to throw up.
Yeah.
Asking about the paste and
So settings. So I think my strong feeling is when we roll this out initially, we should probably all be on the same page with our initial settings, and we can take a look and review this in a couple months. Because I'm going to come to this on the next slide, but I can promise you, this agency we're going to be looked at because we're a leader in doing this, and I want this to go well. So I think potentially we should start out with first line settings for CPAP being 5 to 10. And I'm okay with that range, 5 or 10, that's fine. The BiPAP, I really think if we're putting somebody on BiPAP, now this is not somebody who we're doing a transfer and they're already on BiPAP, right? That's a different story. But we're de novo starting BiPAP therapy. We should probably just start 10 over 5. And we can talk about the exact numbers for the second line, but we can have sort of a second line policy here. These are the second numbers, and if we're getting to the third line, get on the phone.
Makes sense.
Questions, concerns with that? And I'll probably have something in writing that we'll put out just as a sort of agency policy or procedure on the use of BiPAP. We should probably have something wrote down on this that'll have these numbers there.
So, my understanding, when Ramo bought these vents, one of the reasons he was looking at them is to do away with our CPAP, or the Palmidine CPAP that we're using. So if it's just as easy for me to turn this thing on and put any given patient on BiPAP, like say it's a pulmonary edema, is there any disadvantage to using BiPAP for the pulmonary edema patient?
Well, this will do CPAP as well, won't it?
It will, yeah.
And I know the ATV will do CPAP,
The
or
only
the LTV, I mean.
Oh, yeah.
Anyone else is welcome to speak up.
Yeah,
The only
but you
disadvantage
gotta
I
go
can think
pressure
of is that
support.
the ED is probably
It's
gonna
not
switch over to
automatically
CPAP,
listed.
Okay.
just cause that's what we do with CHF.
Goodness. I mean, it's just a matter of settings, but.
All right, administrative notes. So I mentioned this already. So who else is doing this?
I don't know of
Monroe or
any,
Metro?
I don't know of any in the region that are
Okay.
capable of.
Monroe has the
CPAP.
capability with the LTVs, and I think Metro's using LTVs, right, Jim?
Yeah,
So, I
but,
mean, it's-
but we don't have any policy of doing this in the field.
Okay.
You know, we
So-
only use it for SCT
Whether they
transfers.
actually do
You
it or
guys
not.
are
We
2
just,
minutes away from the hospital.
we just got cleared to do blood transfers up there,
Transfusions.
and transfusions, yeah.
So eyes are gonna be on us. It sounds like we're potentially the first agency in the region doing this. And I know that, the region leadership knows about this, and, they're interested in seeing how we implement it and how successful it is down here. So with that in mind, there'll be 100% QI at my level on this. I don't want that to discourage people from using this, because there'll also be QI if it was indicated you didn't use it. But that's mostly, I just wanna look at how it, is this successful? Are we doing this, and is it helping our patients? With a couple things, as with all, problems that we have with potentially sick patients, if you're having a problem with the machine and it's not working, it's affecting your patient, contact the chain of command immediately. We wanna know about this. This isn't like a, we'll need a special report, but this isn't something that can wait till the next day. We wanna know about this. The other thing is, if you just, like this patient that you brought up, Marcus, who's just super agitated and you're debating whether you need to sedate him or what's going on, and they're so hypoxic, these are the patients that you want to get on the horn with either med control or me and sort out in real time. Because we want to make sure that you guys are getting the orders you need, and we're also helping you sort out the management of these challenging patients. Please use it when it's indicated. And really, when we're doing QI on this, I'm going to be looking at, was the right patient given the right therapy at the right time? So were the indications met? Were there no contraindications? If there were contraindications, were they relative or absolute? Did you talk to, maybe a physician about those and get an order? CPAP versus BiPAP, I think I'm more interested in seeing that we're using the BiPAP. If Jim, if you put a CHF on BiPAP, I think that's going to be okay. But it's more the COPDers I'm interested in seeing folks getting comfortable with and using BiPAP. And the asthmatics, right, the obstructive. And then the other thing I want to harp on is not delaying therapy. So if you got somebody who's sick and we're getting them in the rig, trialing a bunch of nebs, giving them Solumetrol, maybe some MAG, or even thinking about Epi, when the whole time they've been breathing 32 times a minute and they're trucking and they're working hard to breathe, probably the first thing we should have done was just put them on the BiPAP or the CPAP. And then we can start initiating those therapies in line or through the device. Because this has probably got the highest mortality and the staving off intubation rate of any of the other therapies that we're going to do. Questions on that?
Do we have a mask in that bag, Jim?
Nope.
The complications with this also, Dr.
Probably
Farney, are
should,
gonna
huh?
be, we only have one of them at
We
this
haven't been using it
point,
for anything with
and,
transfers until
Right.
now,
you know,
but yeah.
We're already carrying.
we're still
four.
trying to, I know we've had a discussion, at least Sam and I have talked, I think Jim and Sam have, we've kind of discussed it, where it's gonna be placed, so
Yeah.
it may not be available, or it just may not be practical if you take a bad respiratory in Portage to wait for the
Yep.
CPAP from Hamburg's Corners.
I
and-
agree wholeheartedly. It's probably worthwhile documenting that, just saying BiPAP not available or impractical, due to distance or
Would it
whatever.
help to have like a somehow have EMS starts trigger a special, just so it's discussed every time?
Yeah,
Maybe
I think we can get,
that's-
that's a good idea.
Not to throw more,
Well, then also.
yeah, not to throw more specials at
What's
people,
that?
but
It
this
also
seems
gives you
like it would be
numbers
useful.
for it.
Yeah.
Well, it,
Simple consideration of
Oh, yeah.
BiPAP.
No,
Consider
us-
BiPAP
You
not
know
available.
what it might do though is if we can keep track of all the times I would have liked to use BiPAP, but it wasn't available because of its location or it's otherwise being used, then that can give us some evidence, hey,
I think the second one's ordered, right, Jim? Is it?
I don't
You
know.
don't know.
I know that Rommel had talked about ordering a couple
Oh, you're
more.
not here. You don't know if it was.
My
ordered?
question,
He
it
knows
might be
nothing.
worth
He
considering.
sits in that chair. Where's the white chair?
What we do with this ventilator right now is it goes generally on the south truck and it goes with whoever the SCT provider is.
Right.
But it might be worth, you know, those jobs are fairly rare, and it might be worth keeping it here at Hampton's for a fly car or a
That's
supervisor to
kind
take
of what we
to
kind of were
a call.
talking about. Karen, is the second vent, is it ordered yet, or is it?
It's in the new budget, it'll be ordered after January first.
Oh, okay, cause we were just talking kind of about maybe a special with when BiPAP was needed, but maybe just wasn't practical or wasn't available, and just kind of wondering if that was something that, you know, maybe when you stepped out, we were talking about it. I was just curious. Thank you.
It's definitely worth something, worth talking about, you know, whether it should be on the truck or here.
Yeah, and there's good arguments for both cases with it. I don't know if they've kind of.
Yeah, cause if you're on a transfer, just an ordinary
Right.
paramedic transfer.
But then how do you, and also you
And
run
that's
on the risk of
outsourced.
justifying if you need it for a vented transfer
Poten-
that's stat, and then.
Potentially, the best way we can sort of, they talked about maybe creating a special report on this. Sort of being able to keep track of all the times that
Do we
we've
still
been
have
able to
the
use it, but we
other
weren't
one?
for practical reasons.
I think
The LT.
realistically,
Oh, no.
Randall's office.
it can be ordered
Is it still there?
as soon as the purchase order is created after January first. I mean, it'll probably arrive before the end of January.
Oh, okay, I didn't know, cause that
Well,
would help
Marcus, that's
alleviate the
interesting.
discussion about where do you
Right.
keep the one vent so that, you know, but if you have one on the north truck, one on the south
And then
truck,
the goal
yeah.
is to just keep buying vents,
Do we
new vents
still-
every year.
Yeah, that
We're,
makes
we're still
a lot of
keeping the
sense.
consumable.
We still have that
box,
LTV?
right?
It's in Ronald's office, I
Yes.
believe, yes.
Right.
So if
we
we
can
still
start
have that
bouncing
LTV,
now.
we could
Yes,
throw that on
yeah,
there.
self-delay.
We could, just keep in mind noises past me for at least 3 times to return it, so we may need to discuss that with their
You
respiratory.
just hide it under your coat as you're walking in.
We could do that, it's not a problem.
Let me quick finish up and then we'll quick fly through these cases so we can get out on time. The last comment I wanna make is please, I don't want Livingston County EMS to be the crew that not that we're gonna do this, but I'm throwing it out there. To be the crew that dumps the patient and takes the BiPAP off in the emergency department and leaves. Right, if we put somebody on BiPAP, it's probably cause they're sick, and leave it on them until either the physicians at the bedside who says you guys can take it off, or they're able to transition over to their own equipment. We don't want,
Document that.
what's that?
So probably document
Yeah.
who and why
Yeah.
said to discontinue that.
Alright, questions? This should be in the PowerPoint, anybody who doesn't have my number, clinical questions come up, you got a super sick patient you wanna talk about, something's not making sense, you got my phone number. Pair up in groups of 2, we'll quick fly through these cases.
I got it.
You got it,
I don't got time, I gotta go.
If you have to leave, that's fine. Jen,
I don't know how to
can you read the first case out loud? So we'll just go through all this together, but, we'll go around the room and read it. I was hoping to split off, so we don't have time.
So at 1400 hours, you are dispatched to attend out the call for treatment. You arrive on scene at single-family residence approximately 8 minutes later. Fire/first responders are on scene caring for the patient. You see an ill-appearing male who appears to be in his 50s sitting in a chair in the kitchen. He's complaining of 9 on 10 substernal chest pressure. His left shoulder is aching. It started yesterday and has been intermittent, lasting 20 to 30 minutes. Stopping and sitting down has helped, but this time the pain isn't going away. He tells you the main reason he called is that now he feels quite short of breath, like I can't breathe. He denies any medical history, medications, or allergies. When you ask him, he says, I haven't seen a doctor in 30 years, I'm a healthy man. On exam, the patient appears ill, diaphoretic. His vitals are heart rate of 120, blood pressure of 160, respiration 26, O2 is 75% on room air. First responders place him on high flow, O2 non-rebreather. His O2 is now 85%. On auscultation, you hear bilateral rales to the mid-lungs. He has pitting bilateral lower extremity.
So anybody can shout this out. What's this patient's problems? What do you think is most likely going on?
You know, they see it.
CHF, yeah, so it's probably a CHF exacerbation, probably because he's having acute coronary syndrome, infarcting his heart, and now he's in CHF. What interventions are indicated?
CPAP.
Excluding that. That's the next question.
Well, you think about nitro, but his pressure's already soft, he may already be in some level of cardiogenic failure, I mean, with a soft pressure like this, maybe he's already infarcting, you know, there could be something else going on with his heart too, so be cautious with nitro.
12 lead would be
I'm on a 12 lead first.
Yeah, I mean, he needs a
high on
12,
the priority
yeah, he needs
list.
a 12 lead, he needs AS.
Not one of those patients that do nitro without a line in,
Right.
a good line
Yep.
in. because
And,
that-
and I agree, I think nitro is probably indicated in this patient, but you gotta respect his blood pressure, he's probably a hypertensive guy, and he's already, probably lower than his normal pressure, but, so, and then, Steve, you already answered the next question, should this patient be placed on non-invasive? Anybody disagree? Everybody see why this guy needs to be on it? He's setting 85 on a non-rebreather, right? CPAP or BiPAP? Why? Why is that? CHF, yeah. I mean, it's a hypoxic respiratory failure right now, right? Would it be totally wrong to put him on BiPAP? No. But I think most providers will probably put this guy on CPAP. What settings? What's your initial CPAP settings?
I'd start them at 7.5.
5 or 10? Well, 5 to 10, I guess. Okay, fine, fair enough. I would do 5 or 10, but anywhere in between there is okay.
I always start at 5, and then
Well,
you
you
can quickly work
figure
up.
physiological peak is 5.
Sure.
So
Yeah.
I
Fair enough.
like
never
to
really
start them
bought
at
that.
7.5.
I mean, if you're adding pressure,
But if we're also worried about his blood pressure,
Then you're
maybe in
adding
this
pressure.
case,
Yeah.
keep a 5, because you're throwing nitro on top of him too, you're gonna really,
Yep.
maybe just give you a little bit of a,
The important thing is I want you to think about the setting, why you're picking that setting. That's perfect discussion for that. And when would you put this guy on the non-invasive? Would you try some things first, give him some aspirin, or what's that, Jason?
Pretty immediate.
Immediately, yeah, it sounds like he needs to be on it, 2 hours.
85%
Yeah.
with a non-rebreather.
All right. Case 2, Rebecca?
At 0500 hours, your dispatch to 6,000 calls at 73 arrived on scene with evacuation. Fire first responders are on scene for evacuation. Seen ill during female who appears to be in her 70s, sitting in a chair in the living room being born. She's complaining of increased productive cough and shortness of breath over the past couple of days. She was coughing off thick yellow phlegm. She increased her homo tube from 2 to 4 last night, but feels worse this morning. She endorses a history of COPD, for which she takes multiple inhalers. She smokes 1.5 packs per day for 30 years, denies any allergies. On exam, the patient appears ill and is working hard to breathe. Her vitals are heart rate 120, blood pressure 160, respiratory rate 30, SATs 86% with 4 liters, being using cannula. First responders placed her on high flow tube via non-rebreather. Her SATs now 94%. On auscultation, you hear markedly diminished bilateral breath sounds, a faint expiratory wheezing and stridor. She was using her neck strap muscles and intercostal muscles to breathe. She speaks in 1 to 2 word sentences.
Anybody shout out, what are the problems with this patient, what's going on?
Sort of COPD exacerbation.
Yeah, it sounds like a COPD exacerbation.
Or it could be pneumonia too.
Could be. Is there hypoxic respiratory failure?
No.
A little bit.
Could be.
86% on a 4 liters. We seem to be fixing that okay with a non-rebreather. Is there probably hypercapnic respiratory failure?
Probably.
Probably. What interventions outside of non-invasive are indicated?
Yep.
Capnic
Nebulization.
that'll help as a diagnostic.
12 lead.
NEBS, 12 leads.
IVs.
What's that?
IVs, and maybe in this case, I mean, it is COPD exacerbation, a little fluid probably wouldn't hurt.
Sure.
Make sure it's not a problem with it.
Maybe some methylprednisolone. All right. What about non-invasive? Is that indicated for this patient?
it looks like she's pretty far along in her disease course, and I think we should, definitely consider it.
Yeah. This is my penultimate case here. Don't be reassured by that 94% SAT, right? This is that patient that I described bringing into the ED. Look at her. I mean, it's hard, I'm trying to describe this in words. If you saw this patient, I think in person, most people would say they're sick.
She's in trouble.
That's 94%, but she's still using a lot of
Yeah.
accessory.
And that's probably representing a hypercapnic respiratory failure that you just haven't been able to diagnose yet.
He I think some people may be, a pitfall here is the faint expiratory wheezing. And it sounds like she's just not moving in air.
Right, so it's exactly what I was trying to get at, so don't be reassured by faint expiratory wheezing, right? That could be just very subtle, just barely wheezing a little bit, or that could be they're so far gone they're hardly moving any air. Like the worst thing that happens when in a bad asthma exacerbation is they stop wheezing.
Yeah.
Buckle up. All right, CPAP or BiPAP?
Like that.
What settings?
Fine.
Within that range for that. Sure.
All right, and when are you gonna put it on? Right away? You gonna wait a little bit, do some stuff?
Right away.
Probably right away, yeah.
It will be,
Okay.
if my partner could be setting up the neb and
Sure.
be setting up the vent.
Rob, can you read case 3?
At 10 a.m., you're called, you're dispatched to a 10 Delta call for a 21-year-old male complaining of trouble breathing. Arrived on scene, the local college dorm approximately 6 minutes later. Fire first responders are on scene caring for the patient. You see a non-toxic appearing male who appears to be in his 20s sitting in a chair in his dorm. Tells you my asthma is acting out. Long-standing history of asthma, but ran out of his inhalers a few days ago. He's been having increasing trouble breathing, coughing, and wheezing over the past couple of days. Denies fevers or other symptoms. On exam, the patient appears well. His vitals are heart rate of 70, blood pressure is 110/60, respiratory rate of 20, SpO2 of 94% on room air. First responders placed him on high flow O2 via non-rebreather. His SpO2 is now 100% on. Auscultation here, diffuse expiratory wheezes. Patient is not using any accessory muscles to breathe. Sitting straight up, not leaning forward, responding to complete sentences.
All right, shout out. What's the problem? What's going on with this patient?
Asthma.
Is it a super severe asthma? Maybe mild to moderate?
Mild to
Mild to moderate, right? Patient, unlike the other two, maybe isn't as far gone. What things could we do to this patient outside of ventilation? Nebs.
Tidal CO2, looking for that obstructive wave
Yep.
form.
Pop the entitled CO2 on. It's probably going to be a bit of a transport. We can get an idea where they're at before we start therapy. Anybody put this patient on non-invasive right now? No. Okay. Let's skip down to the bottom. Rob, can you read the next paragraph in italics?
So, en route to the hospital, the patient gradually becomes more tachypnic and develops respiratory distress. You hear less wheezing, but aren't sure that you're hearing good breath sounds on either side anymore. Continues to mentate, but is having trouble speaking more than a couple words at a time. Do any of your answers above change? If so, which?
So despite what you guys have been doing, this is happening now. What? Who's going to put them on non-invasive now? Probably.
Probably hang mag too.
Yeah, I'd probably start stepping it up. Is what
So,
we're doing.
I've always wondered that about the protocol. The protocol listed epi before mag. How do you feel about that?
I think what they're trying to get at is if you got somebody who's really, really bad,
Sure.
the epi's going to help them before the mag's.
Sure.
Do both.
Mag works really good though.
It does. And I have to tell you, in the emergency department, I feel like I'm giving mag before epi. But if they come in where like they're on the doorstep of being intubated, I'll probably hit them with the epi first.
This patient,
Yeah.
epi's probably pretty safe for him. He's 21 years old,
pretty
assuming he doesn't have anything big underlying. Might be actually a good idea to.
I mean, a lot of times though, you just have that kind of refractory asthma that your nebs aren't working so well on, but they're not so in extremis that you really want to hit them with epi.
And if you're an RSI provider, you get called and the CPAP's not working, you meet standing order criteria, which induction agent, anybody know? Ketamine, right, why?
Because that support of the bronchial effort, and you're also giving them some catecholamine.
Yeah, and it's thought to perhaps help treat bronchospasm. I don't understand the pathophysiology, but
Doesn't it
it's thought to.
open the
Reduce the
bronchi a little bit?
bronchos, exactly, yeah. Alright, Jason, can you read case 4?
0600 hours, you're dispatched to the local skilled nursing facility for a 60-year-old female Delta 6 sick call. You arrive on scene at the SNF residence Approximately 10 minutes later, staff is caring for the patient. You see an unresponsive, obese female who appears to be in her 60s, laying in bed. You are unable to ascertain any history from the patient because she is unresponsive. Staff inform you that she has a long-standing history of CHF, COPD, chronic respiratory failure, pneumonia, coronary artery disease, status post-MI, and diabetes.
Generally healthy.
Yeah, right?
Trainer.
All of it.
On morning rounds, providers found her unresponsive. No kidding. She was breathing and had a pulse. They called 911. On exam, the patient is unresponsive. With a GCS of 6, her vitals are 100 on a heart rate, BP of 150 over 80, respiratory rate of 30, SpO2 of 80% on a non-rebreather mask. On auscultation, yeah, right, you hear bilateral rails to the mid-lungs, diffuse rails, breath sounds are symmetric.
By the way, I don't think we read this before, but at the top of the first page, for all these cases, assume your nearest ED is 20 minutes away and your nearest major receiving facility is 45 minutes. So typical in Houston County. Alright, so that's your situation. What's this patient's problem? What do you think's going on? What could be going on? This isn't as obvious as some of the other ones.
She's sick.
Yeah, I mean, her main problem is she's sick. This could be a bunch of things, right?
This could be,
Reset
this
button.
could be respiratory,
This could be respiratory.
and,
This is like that patient. Yeah.
ventilatory failure.
I mean, she could be hypoglycemic. Who knows what's going on with this patient?
I think at this
The
point you've
difficult
got-
ones are ones that have elements of both disease processes
Yeah.
going on.
The
and that
type 2
happens
respiratory
quite a bit.
failures.
Yeah.
Yeah.
At this point, we're tied up on ABC issues right
Yeah.
walking through the door. I think that takes precedence, as we've got to get
Yeah,
her
good point.
at least the initial assessment and the initial life threats done, and then we can try to sort out, okay,
Yeah.
where do we go from here?
So should this patient be placed on non-invasive?
No,
No.
Why not?
unresponsive.
Yeah.
Right, contraindication, right? What does this patient probably need?
Intubation.
RSI.
Yeah, it probably needs to be ventilated definitively with
Valid
either a
DNR,
BLS in a
DNR.
way, and,
Check her BG.
she's probably gonna need a standing order for, RSI,
She's
so
a
now we
CHF
request RSI
lying
on
flat.
this patient. Alright, that was the general gist. I wanna make sure that we weren't gonna put this patient on BiPAP. Everybody know why? Everybody understand that? Nobody's putting this patient on BiPAP. Alright. Last case, Steve Remarcus. Steve, you got it right in front of you.
0800, you were requested to the scene of a hazmat exposure at the local dairy plant. You arrive on scene 5 minutes later and report to incident command. Incident command informs you that you have one patient who was exposed to anhydrous ammonia, now complaining of severe shortness of breath. You see an ill-appearing male who appears to be in his 40s sitting in the hazmat tent. Status post-decontamination. Firefighters tell you the patient was a worker at the plant when anhydrous ammonia tank began leaking and the patient inhaled the fumes. He has developed increasing trouble breathing over the subsequent 20 minutes. He denies any medical history, medications, or allergies. On exam, the patient appears sick. Vitals are heart rate of 120, blood pressure 120 over 70, respiratory rate of 26. SpO2 of 91% on room air. First responders placed him on high flow O2. The non-rebreather, his SpO2 is now 95%. On auscultation, you hear bilateral rails throughout. No physical finding, exam findings.
What's wrong with this patient?
Flash pulmonary edema.
Right, probably from the inhalation exposure. What can we do for this patient?
CPAP will be run.
Yeah, pretty much. There's not gonna be a whole lot, I mean, ABC is supportive care, but, what I wanted to hit on, this is rare, but could this happen in our county?
Yeah.
We got a crop plant.
We got
They
plenty of
have-
farms.
Yeah, lots of farms. We
Yeah,
have
the chemical plants too, most
Yep.
of them around here have.
Yeah, so we have this stuff kicking around, it's just a matter of time. That'd be great if we could report that to the region, that we, use this for that. Okay, that's all I got. Time's up, so, welcome to stick around, ask me questions afterward, but, that's it. Thank you all for being here, appreciate it.
Are there any ALS providers here that are not familiar